My name is Paul Gagne. I'm a vascular surgeon out of Norwalk Hospital. Hal just alluded to the breakdown of the venous system into the deep system, the superficial system, and the perforator system. A lot of the treatment of the perforators is linked to the superficial system. So I'm going to spend some time talking about treatment of the deep system. And I'm going to focus on both the acute and the chronic. Hal was talking a lot about the chronic in those pictures. But in many patients, the acute leads to the chronic, and so I want to start there. So acute DVT affects about 200,000 Americans a year. If you're a young teenager, it's fairly uncommon, 5 per 100,000. But if you're 80 years old, it could be as many as 500 patients per 100,000. So it's a linear progression throughout the course of your life. 7% of the patients in the first 6 months after their initial acute DVT will have recurrence. So it can be a real nagging problem in patients. I want to point out that we're getting into the cold part of the year, and this is a little known fact, that this is the time of year when we see most of the DVTs, the fall and the winter. Nobody fully understands why that's the case. It's more common in Caucasians and African Americans than Hispanics and Asians. Next, please. So, to steal Hal's slide, and I gave him credit for it, so this is the anatomy that I want to focus on for the majority of this talk. The common iliac, external iliac, common femoral vein, and just a little bit of the most superior cranial portion of the femoral vein. Next, please. And I'm going to talk a lot about the common iliac vein. Hal alluded to the crossing of the artery over the vein here. We'll talk about that. And then the vein going down through the pelvis into the common femoral at the level of the hip. Next, please. So, acute DVT, by definition, acute meaning it just happened, can easily become a chronic disease, like this patient here. Anticoagulation is effective for stopping propagation of clot and for preventing pulmonary emboli. But 40% of patients who have a proximal DVT, and a proximal DVT is the common iliac vein, the external iliac vein, the common femoral vein, and some people would consider maybe the superior portion of the femoral vein. But if you stay with the first three, you're safe. If you have a DVT that's occlusive in those three segments, you have a greater than 40% chance of developing the post-thrombotic syndrome. And we'll talk about that a little bit more in a second. And you have a 4% chance of developing the most severe forms. And that can be both physically and mentally demanding and disabling. And that's where we transition from an acute disease, if managed, what I would argue is inappropriate in this day and age, can become a chronic disease. Next, please. This is the post-thrombotic syndrome. So you can see here the stigmata that Hal was just talking about. You've got the sores, you've got the darkening of the skin, you've got swelling, you can see by the shininess of the skin. These are the advanced venous hypertension. This is a patient who has the lipodermatosclerosis and venous ulceration. These are C6. They often will tell you that they have swelling, heaviness, cramps in their legs. They may have itching and these open wounds. So this is what a simple DVT, and I use the term simple loosely, can turn into if it's in the wrong place and managed inappropriately. Next, please. Now, this chronic disease accounts for 75% of the cost of a DVT, this post-thrombotic syndrome. So most of the burden to the economic system and to the patient is not at the time of their DVT, although they hate that. It's down the road when they start suffering from the more chronic problems. And it's estimated that about $200 million a year is spent on just the economic part of just the post-thrombotic syndrome, not the initial event. More importantly, the quality of life scores for patients who get the post-thrombotic syndrome are miserable. Initially, in that 2 years, which is the period of time where most patients are going to exhibit their symptoms, their quality of life scores are on par with COPD and diabetes. It becomes a nagging chronic problem. And in the most severe forms of post-thrombotic syndrome, it's on par with chronic angina, cancer, and congestive heart failure. So we think of acute DVT as being, oh, you got a DVT, put them on anticoagulation, send them out, and they'll be fine. But there's a large group of these patients who are not fine. And that's the group I particularly want to focus on tonight, because we have an opportunity to help them, but you have a narrow window. It has to be within the first couple to 4 weeks after their acute DVT if you're going to do anything other than anticoagulation and compression. So you have to be thinking about this part of the equation early on in the treatment algorithm, because once you get to 4 or 5 weeks, you're really behind the 8 ball. In many cases, the horse is out of the barn. We will talk about some options that we have, but that's a critical piece of information that I hope you take from tonight. Next slide. If you look at the claims data, and this was a study that was published in 2006 on the management of acute DVT and post-thrombotic syndrome. If you look over a 7-year period, they looked at 27,000 patients in a managed care organization, and they annualized the cost for acute DVT. The cost for acute DVT is $17,000 versus matched controls for patients who did not have a DVT of only $700. The pharmacy costs $4,000 versus $600 for the same group. So an acute DVT is expensive. But if you have a post-thrombotic syndrome on top of a DVT, then they then cost another $11,000 a year for the rest of that patient's life. Next, please. So let's just imagine a 40-year-old male or female who develops post-thrombotic syndrome from an acute iliofemoral DVT. They just are treated with anticoagulation and compression, so now they have an occluded vein. It's $11,000 for the next 30 years of their life. And that's just for their one disease process. And so if you figure there's 200,000 new DVTs a year, every year, over 5 years, you're up to 1 million. You can start doing the math and see how this progresses rather quickly. More importantly, they then can spend 30 years of their life, a young person who's otherwise productive, with a miserable existence, as I said, on par with COPD or congestive heart failure. So this is the hard part of this disease process that we have to keep in mind when we see that patient with the acute DVT. Next, please. Now, we've known for 20 years that if you open the vein, if you have an occluded common femoral and iliac vein from an acute DVT, if you open the vein, as a group, these patients will do better. This was a study published by Platt et al. Now, this was before we had minimally invasive techniques, so this was a problem at the time for wide adoption, but this was a surgical thrombectomy with anticoagulation versus anticoagulation and compression alone. So it's medical therapy versus medical and surgical. And what they saw in follow-up is that 10 years, the incidence of ulceration was higher in the anticoagulation group, and the incidence of swelling was higher in the anticoagulation group. If you can open up the vein and get flow through, you've gotten rid of the obstruction part of the equation that Hal was talking about. You may still have reflux, but you got rid of the obstruction part, and that's an important characteristic because the combination of reflux and obstruction is the single biggest predictor of long-term severe symptoms. Next, please. Now, let me suggest what I think is the proper treatment of acute DVT. If you have a clot if you have thrombus occluding the iliac and common femoral vein, you should be considering lysis. And that's going to be done in the first week or two following the diagnosis, because after that it gets that much harder. That doesn't mean everybody gets lysis because there are certain contraindications, but this should be considered. This should be part of the thought process. Now, if you have a femoral popliteal vein occlusive DVT, so that's what used to be called the superficial femoral vein, but we've abandoned that terminology. The standard of care today is anticoagulation and compression. Now, there is some data to suggest that patients with occlusive femoral vein DVT may benefit from lysis, but that data is a little bit on the light side at the moment. 2 years, 2017, the ATTRACT study should be published. That's been going on for the last decade. They're looking specifically at this equation, or this question, and I think we'll have a different answer. But for now, this is not the standard of care. Standard of care is anticoagulation and compression. But what I would point out is there is a group of patients, they have popliteal vein occlusive disease from their acute DVT. They oftentimes have clot involving multiple tibial veins. And they, a week into their anticoagulation and compression, aren't really getting better. They're swollen, they have a lot of pain, they're not doing well. And these patients can develop fairly significant post-thrombotic syndrome. And this is a subgroup of the FEM-POP group that I think you should pay a particular attention to. If they're not getting better after a week or so of conservative measures, and especially if they're young and active, then you might want to think about this group being evaluated, or at least have a discussion about thrombolysis, because they can have long-term problems. Next, please. This is the Cavan study. Now, there have been a large number of studies looking at anticoagulation versus anticoagulation with thrombolysis for acute DVT. And I don't want to go through all the literature in the nature in the interest of time, but this is the most recent study, and this is the only randomized study to date, prospectively, that looked at this. Now, this study looked at femoral vein, the superior portion of the femoral vein, common femoral vein, iliac vein, occlusive DVT, and randomized to anticoagulation or anticoagulation with thrombolysis. And although it wasn't a perfect study, the consensus is, and as I see highlighted here, there was a statistically meaningful difference in the incidence of post-thrombotic syndrome at 2 years and in the incidence of patency of the iliofemoral segments in the first 6 months as evaluated. And so, again, reiterating what I said earlier, what we've known for 20 years, if you open the vein up and then anticoagulate them, they tend to do better in the long run than if you just anticoagulate them. Next. Now, this is a real quick example of what this looks like. I don't know how well it's projecting in the back, but on this top left panel is a patient with a thrombosis of the popliteal femoral and common femoral vein. You see a little wisp of contrast tracking up along the acute DVT, but the vein is thrombosed and occluded, extending up to the groin area. And what we did was we opened this up through thrombolysis, restoring flow in this patient from the knee up through the iliac vein segments. This particular case took 2 hours. This was not a 2-day in the ICU thrombolysis that I grew up with when I was a resident. This was a 2-hour case, and in fact, the treatment times for thrombolysis are now generally in the vicinity of a few hours to maybe 12 to 18 hours, which cuts down on a lot of the complications we saw when I was but a wee lad in medicine. So I would say to you that we can do this rather safely in the majority of patients. Next, please. So JACO, which is one of the accrediting bodies for the hospitals, made a statement now about half a dozen years ago that we ought to be thinking more about DVT patients, both for prevention and treatment, and that there are selected patients that ought to be considered for thrombolysis. And mechanical thrombolysis is just an accelerated way of clearing the clot to decrease the complications. And that the main goal of that was to prevent the post-thrombotic syndrome because of all the disease and complications associated with this. They happen to make a plug for vascular surgery, but we won't go there tonight. Next, please. So in summary, I'm going to ask you to consider, when you see those DVTs this winter, especially when they're involving the common femoral and iliac veins, don't let that acute DVT become a chronic disease. It's an expensive problem for the patient and for the healthcare system. It's a significant decrease in that patient's quality of life. Consider lysis, especially in the first week or two, because that's really the time frame that we need to act. And keep acute DVT an acute disease. Next, I'll get off that soapbox now. But I always like to make that pitch in the fall because this is the time where we see these patients. Now, I'm going to shift a little bit to chronic disease. And the standard of chronic disease has been compression. You heard about stockings. Who knows what an Uniboot is? Raise your hand. All right, good. So most everybody knows what an Uniboot, a very kind of an old-fashioned compression bandage that still is used. Next slide, please. So we have about 6.5 million people in the country who have advanced venous hypertension, lipodermatosclerosis, ulceration, or healed ulcers. It's a huge problem. Next, please. This is the face of chronic venous insufficiency. Hal suggested or somebody might use the SEEP score. Well, I'm taking advantage of that. These are SEEP 3 through 6 in a mixture. The swelling, stasis dermatitis that you see here and here, the eczema, the ulceration, hyperpigmentation. This is the face of advanced venous hypertension. These are the patients I'm going to be talking about now for the rest of this conversation. Next, please. So a study was done in the UK back in 1997, looking at the cost to their national health care system, their single-payer system, of chronic venous insufficiency, this advanced disease and ulceration. and they estimated that 400,000 pounds of their budget was being spent annually, which calculated in 1997 to $617 million US dollars. If you now account for inflation and put those dollars into today's dollars, the cost is just under $1 billion a year in US dollars for the treatment of this most advanced form of chronic venous insufficiency. These aren't varicose veins. These are people who are suffering tissue injury because of their venous disease. So it's a very large problem. It's about 1 to 2% of the healthcare budgets in the national healthcare systems that we see in Europe. So if you're thinking about, as we move into a one-payer system or population health, venous disease is not a small problem, and it's certainly, if you think that 1 out of every $100 in the U.S. is spent on that, that's not a minor issue. Next, please. So, sorry about this for dinner, but these are some pretty significant venous ulcers that the wound centers see on a regular basis. And this is how we used to treat them. We'd wrap them up with Unna boots. We'd tell them to elevate their legs. The Unna boots would slip. They'd get wet. The wounds would not necessarily get better. Next slide, please. You'd be 6 months into changing these bandages once a week. The wounds haven't gotten much better, and yet, you know, you're doing your best. The doctor's unhappy. The patient's unhappy. And this is what led me to the next slide, please, to think there had to be a better way. And the better way has turned out to be evaluation of venous outflow obstruction in the pelvis and treating that outflow obstruction with stents. Next, please. Now, there's different types of disease that you'll see in the iliac and common femoral veins. You may see the post-thrombotic disease, strictures, sclerosis, narrowings, that we've talked about already in the first part of this talk. And these are just scar tissue that builds up within the veins. And if you can imagine 95 going from 3 lanes down to 1, what happens? Everybody's got a headache because of congestion in traffic. That's what happens in these veins. Now, what's really interesting is if you look at the veins of many of these patients who have these severe diseases, severe venous symptoms, you'll ask them, have you ever had a DVT? And they'll say no. And then you'll image their veins, and you see obvious scar that shows DVT. So there are many patients who have had a DVT and never even knew it or never had it diagnosed. And you can imagine, if you had a total knee or a total hip replacement, you always have a swollen leg, you could easily have a DVT in there, and if they don't look for it, they don't find it. But that total hip may have chronic venous outflow obstruction 2 years later, and that's your opportunity to go looking for the problem that you can then fix. The other big revelation in this field, which was pioneered by 2 doctors in Mississippi, Doctors Raju and Neglin, back around 2002, they first described the concept of compression of the iliac veins by the overlying artery. Now, we've known about compression of the left common iliac vein, described as the May-Thurner syndrome, for at least 3 to 4 decades, going back into the 40s and 50s. So I guess it's getting closer to 5 decades, or 6 maybe, huh, Andrew? And so we've known that this happens, but what we didn't know is that you could get compression of the right leg veins, and that was one of the revelations. But the other revelation was that you can find this problem with intravascular ultrasound. Next, please. You start with an ultrasound, but you're not going to see it. You may see disease in the femoral vein or the common femoral vein or the superficial femoral vein, but you're not going to get a good look in most patients at what's going on in the pelvis. It's just not technically possible at this point in time. Next, please. And so you start thinking what else we can do, and Neglin and Raju looked at these veins using intravascular ultrasound and found that you could detect compression, you could detect scar tissue in these veins if you put the catheter in. And this is a percutaneous procedure, just like a coronary catheterization. Next, please. And what you see is you see compression here, the blue being the veins, the red being the arteries. You see compression of the common iliac vein on the left by the overriding artery, but that same artery can compress the common iliac vein on the right, and then where the artery bifurcates into the external and internal iliac arteries, it can pinch off the external iliac veins as well, and occasionally you'll see compression of the common femoral veins at the inguinal ligament. Next, please. This was one of their important studies. This was a report in 2007 from the same authors. About 1,000 patients, and this was a mixture of compression and post-thrombotic disease, patients with SEEP 3 through 6. And they went ahead and identified these patients. They treated them with stents. They had almost 10-year follow-up in some of their patients, although the experience was certainly weighted in a more recent part of their experience. And what they saw, which was very important to me as an interventionalist, was that when they put stents in these patients, they weren't creating a lot of new DVTs, because that was certainly my reservation when I first heard about this in 2006. And in fact, the incidence of thrombosis is very low peri-procedural, and even long-term, only a few percentage of the time. Next, please. More importantly, what they saw is when they stented, these are compression lesions now, that about 80% of the patients got rid of their heaviness, the achiness in their legs. 75% of the patients healed their ulcers. And more importantly, the standard of treatment used to be heal the ulcer, keep them in compression. Many of these patients go on to not needing compression because you've healed the underlying problem. Now, this isn't a panacea. This doesn't solve everybody's problem, but it's amazing how many people you can really fix this way. This is post-thrombotic disease. This is an external iliac vein. You see how ratty it is. This is a venogram, common iliac vein on this side. Clearly, if you see this, you know you have a problem. You don't need any other imaging to understand what you're up against. Next, please. But if you see a venogram like this, where you don't really see any specific narrowing, this is common iliac vein, external, common femoral. This is all relatively normal. You're not really sure if you have outflow obstruction, and that's where intravascular ultrasound becomes very helpful. Next, please. This is the IVUS catheter. Catheter is inside the vein, and it shoots out an ultrasound wave around the tip of the catheter. It bounces back to a processor in the catheter, and it creates a picture, and you can see scar tissue, you can see narrowing of the vein. Next, please. This is a slide just to emphasize this. If you see this venogram, this is compression of the left common iliac vein by the overriding artery with collateral flow. You rarely see this nice a picture, but it helps to image. This is a vein on IVUS. Here's the catheter in the middle. Here's a normal vein. Here's a flattened vein, not small, but just deformed. And this is a vein which is not much bigger than the catheter inside it. This is a tight compression. These are outflow lesions that if you treat, these patients get better. Next. So just to illustrate, this is a patient who was 65 years old, a woman early on, around 2009. She had C4 disease, so she had swelling, and she had stasis dermatitis. She had no history of DVT or prior vein surgery. She had no systemic reasons to have swelling. She had been having swelling and heaviness in the leg for the last 3 years. And on exam, she had a swelling and stasis dermatitis. Her lower extremity duplex was normal. Next, please. This is her venogram. You see no collaterals. You see nice brisk flow through. This is a pretty normal study. Next, please. This is what it looks like when you stop it, the picture I showed you earlier. Really nothing to see. And this is her IVUS. This is the IVUS catheter. This is a wire from the other leg. This is the inferior vena cava. You can see the other iliac vein. We're now in the iliac vein here. Here's the artery overriding it, deforming it a little bit, but not narrowing it. You see the two arteries here? This is the paired common iliac artery. Here's the vein, the catheter here. This vein's going to split in a second as this splits. Here's the artery splitting. The vein is going to compress here. Keep an eye on that. Unfortunately, I sometimes watch these pictures rather than pull the catheter back because I'm so amazed. You can see it getting narrowed. And if you give me 1 second longer. You can see how tight this gets. There's almost no lumen there. That's the lady I showed you her venogram on a few minutes ago. Looked fairly normal, and yet she had this very tight compression. And if we pull the catheter down a little bit, lower it towards the groin, you can see the vein is perfectly normal below that. So she has a short segment, very severe stenosis due to compression in her iliac vein. Next, John, please. This is the compression. This is the normal vein. This calculates out to about an 80% stenosis. Next, please. And if this is up in the cava again, same artery compressing here. We see the two arteries, the vein deformed, and we'll show you what a stent, where we put a stent in there to open that stenosis up. The artery is going to split here. That's the area where we saw the narrowing. You can see the wall of the stent here, and now the vein's widely patent. This can be done under local anesthesia, and it's a day procedure. Next, please. This lady, a week later, her heaviness was gone. She could see her ankles. She was so happy. And this is a common scenario that when you find these patients with these high-grade compressions, they can get very dramatic and fairly quick relief from these symptoms. Next, please. So In conclusion, the treatment of acute DVT, consider lysis in appropriate patients. If you have chronic venous insufficiency, don't be nihilistic about it. You need a full evaluation of the deep and superficial system, as Hal said, and you may be benefiting these patients with intervention into their iliac and common femoral veins. Next, please. The cost of watchful waiting for venous disease is not small. Same as with nihilistic view of the disease. You have increased suffering for the patients, increased personal costs because many of these patients lose days at work, and you increase costs to the healthcare system. So if you treat the disease, you decrease all these problems, and everybody's happier. Next, please. Now, I just want to highlight where this field is going, because these are some of the trials that we're running in this area currently down at Norwalk. The video study it was started about 2 years ago, and it's the first in the U.S. venous stent. The stents we've been using have been off-label up to this point, and we're currently enrolling. That's going to be a 3-year follow-up. The Vivo study, the video study rather, we've completed enrollment. This was a prospective study looking at comparing venography versus intravascular ultrasound for diagnosing these lesions in anticipation of treatment. The ACCESS study is a study using thrombolytic techniques for treating chronic venous occlusive disease and post-thrombotic disease to try to open up the veins and gain a channel to decompress them. Next, Steve. The Virtus study we just started, and again, this is the second in the U.S. venous stent study. There's only 2 venous stent studies going on in the country right now. We're part of both of them. So that's, again, representative of our commitment to this area. And then we've now started an arm vein study because there's possibilities of using those IVs that all our patients have in the hospital for drawing blood rather than having to stick them each and every time we want a new blood specimen. And we're doing some work on arm vein anatomy to help that cause. Next, please. Thank you.